didn't know I did all that. Well, can everybody hear me, or do we need a microphone?
People don't hear well. Use the mic, please.
What? Okay, well, this is going to be a little bit different kind of talk. There's no slides, there's no tables. Even though I'm a urologist, there are no p-values. And we're going to just talk. Before I leave tonight, I promise you, everybody here, if you have a question, I will answer it. So you can't leave this room tonight without any question you have unanswered. You may not like the answer. I may have to make up the answer, but you will get an answer. The reason most of you are here is because there's something going on. You have questions, you have concerns, and so we picked a little bit of business about the prostate to talk about, and then I have brought my entire encyclopedia of knowledge here. I have an article that will back up pretty much anything I say, I hope. And so if you have any questions about anything, sometimes when we get into these things, it's good to look back to see where we've come from. When I was first a resident, we used to examine people with our digital exam, and that's how we diagnosed prostate cancer. And as we all probably have read or been told, that's a terrible way to find prostate cancer because it has to be really spread and come out to the surface before you feel it. I was in practice 41 years. I only diagnosed one fellow with the digital rectal exam. And yet we bought over 400 dozen gloves over the period of time. And you can't imagine, well, maybe you can, the number of KY gel containers that we used. The fact is, they're not doing digital rectal exams anymore. It's a recommendation from some group. It seems like it's a shame because you could figure out where the guy's wallet was and how thick the wallet was, and so it's an area that really should be looked at. But because it's so useless as far as prostate cancer, it's been done away with. And when in the mid-70s, late 70s, early 80s, when PSA came around, wow, we thought we had it made because there was never going to be a case of prostate cancer that was going to go undiagnosed. Well, now they tell us don't do PSAs. And the national recommendations are, if you do a PSA, make sure the patient understands that 3/4 of the PSAs are going to lead to unnecessary biopsies and pain and suffering. Sepsis is, the bacteria are becoming resistant to the antibiotics. Sepsis is now up to 3 or 4%. It's a very significant thing. We used to think of the prostate biopsies as kind of an annuity because PSAs were so commonly elevated, and you could do a biopsy, so it became a regular part of our culture. We used to do 8 or 10 biopsies a week with the ultrasound, and someone figured out how to numb up the prostate with a little lidocaine so it wasn't particularly painful, and so it became something that was done. And our leaders like Don Skinner and the guy from Johns Hopkins, they became very famous because they did 1,200 or they did 2,000 radical prostatectomies. And then one of the significant things that happened was they discovered that about 60% of the prostates that were taken out or radiated didn't need to have anything done. Expectant treatment wasn't popular then, but the low-grade prostate cancers, the fellow was more apt to get killed on the freeway, he was more apt to have a stroke, a heart attack, something else. So 60% of what made those guys famous, they didn't even need to be done. And that was quite a blow to most of us because our egos are involved with how good of surgeons we are and how good you can radiate someone, to discover that the guys that really did well were the ones that didn't need anything. Well, that's an embarrassment to everybody. There's no question. We didn't know it at the time, but in retrospect, it's an embarrassment. It's like electing Trump. You didn't know it at the time, but look what we ended up with. He's probably going to win another one. By the way, I guess Biden got in today or yesterday. So all the women with the hairspray, and then he's going to go around smelling and hugging, and you know, this is going to be quite an election. We're not supposed to talk about politics. So in 1941, there was 2 urologists who quite accidentally discovered that men that had prostate cancer. In 1941, the only diagnosis was when it got to your spine and it hurt, because they didn't have any other way to tell. They weren't even doing many biopsies. One of their patients got in a car wreck and lost both of his testicles. Now in California, you can lose testicles as part of a prenup, but very seldom do you see testicular loss as a car accident. That's actually, think about it. I mean, how do you, unless they're over your shoulder or something, how do you lose them in a car wreck? Well, that guy's prostate cancer got better. And they thought, how are we going to talk guys into losing their testicles to make their prostate cancer better? But they did, and they got the Nobel Prize for it. I mean, it was quite a significant thing. And then after a while, they discovered that they quit getting well. They escaped. The prostate cancer started to grow again, and that's when the escape phenomenon was discovered. And that's when we discovered that if your prostate cancer came back, we had nothing. Once you gave hormone or took away hormones, you didn't have much left. And so that was something that, you know, eventually the disease became resistant, and then that was it. Now, the largest group of prostate cancer patients now has become the group that have been treated with either surgery or radiation or radioactive seeds, and then the PSA comes back. That's been decided, they've made a new category for that. There are 60,000 people in this country now that have rising PSAs after primary treatment. It's going to be soon the largest group that we have. And in case any of you fall asleep, the end of this talk is some exciting news about a treatment for that. So that's just a little preview. There is going to, this talk is going to make sense in a little while, maybe. This new category is where all of the research is being done. Drug companies are racing each other to come up with new medications, and this is just the way it's going to be. That plus the MRI guided biopsy. Did anybody have one of those? Yeah. How'd you like that MRI?
Better than the biopsy.
Oh, yeah. Well, the fact is, once they learned what prostate cancer looked like on an MRI, and then married it to the ultrasound, it really made taking the biopsies a lot more sensitive. That happened just as I was retiring, but we would send a fellow to get an MRI. There was software that would put it in your computer that was on your ultrasound machine, and then it would show you where to take biopsies. So rather than just doing random biopsies, we were doing targeted biopsies. Well, you find more incidental cancer that way, but you also find more high-grade cancer. So it's a much, much better way to go. And then if you take that specimen and do genetic testing on it, which of course none of the HMOs or PPOs or Medicare want to cover, you can actually tell which patient needs treatment and which one doesn't. And if you don't need treatment, you go on the expectant treatment. We used to call it watchful waiting. They changed the name for some reason, but it's not just doing nothing. You have to have PSAs frequently. It involves repeat biopsies, but you actively don't do anything. And most of us are really, really good at that. Actively not doing anything is a form of recreation for a lot of us. So it keeps us out of the surgery room, and it's very helpful. Why the insurance companies don't want to cover it is because it's expensive. My brother-in-law happens to be the CMO of the Oncocyte company, which is the biggest one: breast cancer, colon cancer, prostate cancer, and they can't get Medicare to pay for it, they go around and lecture and they show how beneficial it is, and it's just so expensive that nobody wants to cover it. So if you got an extra $4,000 or $5,000 that you want to have a genetic test, it's very important because it individualizes the treatment, and they now know what genetic defects to look for. So they can say the guy in the blue shirt needs treatment, the guy in the white shirt doesn't. And it's even more sensitive than just a Gleason score. So if anyone needs or is going to have a biopsy, or if you have an old biopsy specimen and are wondering, that test is really worth the money, because you can take a lot of grief out of your life, not worrying about whether your cancer is going to be a problem. So it's called active surveillance, and it's not that you don't do anything. You have to have repeat biopsies once every 2 years, 18 months to 2 years, a PSA every couple months or twice a year. Of course, Medicare won't pay for PSAs anymore, or they don't want to, or they often don't pay for them. And then you can get away with not having the digital rectal exam. So the treatment. Everybody knows that it's the gospel of prostate cancer. You have radiation by many different means. You have radioactive seeds, and you have surgery. Those are the three main treatments. There's cryo, where you freeze it. Has never caught on. It just doesn't seem to be, it's not easy to do for one thing, but it just has never really caught on. HIFU, the high frequency, kind of came and went. It's a long treatment, and it just hasn't also caught on very well. So people that have Gleason 7, 8, 9, and 10 have to decide whether they're going to have treatment and what it's going to be. And it really should be individualized by the genetic testing. So the genetic testing is turning out, I don't know if O.J. Simpson knew this, but the DNA testing is really important. And you know, when O.J. got nailed by it, why? It was one thing. And here it's being used in a really positive way. We all know about androgen suppression. If you take away male hormone, prostate cancer stops for a while. Could be a little while, could be a long while. So androgen suppression can be done by medicine, oral, by shots, by surgery, and it is very effective for a period of time. I've had patients that went 20 years with androgen suppression before it escaped. We had other people that right away after androgen suppression, the disease advanced. We now know why, because of the genetic studies, the DNA problems or the deficits that they find. So we could identify the guy ahead of time, and that's the person that should get the kitchen sink. Everything, including the kitchen sink. The guys that have favorable genetics, they can go fishing, they can go do what they want, and they don't have to worry so much about it. So this new group of people, again, is when the PSA goes up, but they have no metastatic disease. Now, someone just mentioned something about a new test for determining metastatic disease, and there are 4 or 5 new tests that are out there. Again, no one's going to pay for them. And it takes years to get them to pay for them. It may be that more men have metastatic disease than we know about. So about 6 years ago, they went out on the street of New York and they tapped men on the shoulder that looked above 60, drew a blood test. Men had to say they didn't have prostate cancer. And 13% of them had circulating prostate cancer cells with no symptoms. Then when DNA analysis came, they did the same study, a different group of people, I think it was still New York, DNA fragments were found in almost half of the people. So we know that there are men walking around that their body is fighting prostate cancer. And those fellas do not have clinically evident disease. And when they followed them, they've only followed them for 4 or 5 years. Most of them are not getting prostate cancer. So their immune system must be doing something to kill those bad cells. So we know there's a whole group of guys that have it, but don't know it, and may never know it. And that's what the very key for this whole thing. Identify the person that has the bad stuff and treat the heck out of that person. The PET scan using the prostate-specific ligand thing is what this program is about that he was talking about. And it's really amazing. It's showing disease where we didn't really know, where regular bone scans don't show it. So, how did we get prostate cancer under control once it escapes? Well, that's the androgen suppression therapy. And some of you have probably had Zoladex or Lupron or Casodex or flutamide. Those were the standard ways. They're shots. Some of them, we used to put a pellet under the skin that was good for a year. And those are the ways you suppress male hormone. It's very ingenious that they figured out the hypothalamus inside by the pituitary tells the pituitary what to do. The pituitary tells the testicles what to do. There's always somebody trying to tell you what to do. And when you block that by many different ways, then of course we get this good response. The side effects, you lose your sex drive. There are problems with erections. Weakened bones were osteoporosis. DEXA scans became popular not only with women that have osteoporosis, but also in men. And then a whole new group of treatments for frail bones, Zometa and all of the different medications that are given to build up the bones came on the scene. So we shouldn't be seeing very many fractures now in prostate cancer treatment. Then there's a group of men that have been treated with hormones and the PSA goes up again. And so those are castrate resistant. That means the hormone treatment has quit working. And for those men, there are several things available. One is chemotherapy. Now, I don't know about you, but I don't look forward to my day of chemotherapy. The chemotherapy today is pretty much as rugged as it used to be. Your hair falls out, you throw up, get sores in your... It's not a fun thing to go through. But it's one of the first things that has helped that group of castrate-resistant men. In fact, they came out with a second medicine for people that don't do well on the first medicine. So if chemotherapy is going to be used, there at least is some rationale to it. And then the vaccine. Has anybody talked to the group about the vaccine? Provenge, it's been around since 2011, I think. It's really amazing. They draw your blood, they find little cells in your blood called dendrites. And those are the cells that tell other cells what to do. I thought we called those wives, but now we call them dendrites. They send that to a lab, and they found that certain insects have prostates. Now try and do a digital rectal exam on a mosquito. You know, when we were researching this, one of the lubricants they used to use was black flag, but that didn't work out so good for the insect. So the insect that has the prostate gets ground up, and the dendrites are introduced to prostate cancer. And the dendrites go back to the patient and go in their system, and believe it or not, it's actually been quite useful. You get some side effects, but in men, it's approved only after everything else doesn't work. Again, very expensive, very unlikely that an HMO is going to cover it. Interestingly enough, Medicare does cover most of it. I think because a couple of congressmen got prostate cancer, they needed it. So it's just a very, very interesting way. There hasn't been a second vaccine made, but they're certainly working on it. The Lupron works, as I mentioned, by telling the pituitary to quiet down And the big news and the thing that really want to talk about tonight is the development of some new ways to treat the prostate cancer, both the rising PSA, which is going to be soon the largest group of men, and the people that have gone through hormone therapy and it doesn't work anymore. So what used to be the fellows we didn't have a lot to offer, all of a sudden there's all these new drugs. And the first one is called abiraterone. I've been practicing for 3 weeks to say these words. But once you retire, sometimes these words don't come as easy as they used to. But abiraterone is a medicine that was shown to turn off the hormones, and not only from the testicle, but the ones that come from the adrenal gland. So it has to be taken with prednisone to replace what it destroys. And it was shown for one of the first times that there was something that actually worked when nothing else was available. And that had no more been approved at $10,000 a month. And then a drug came out called enzalutamide, and otherwise known as Zanti. And they're just advertising the heck out of that. And that was a drug, there's an old drug called Castrate. They took it, they dolled it up, brought it out as a new drug. The problem was it caused seizures. And for some reason, it crossed the blood-brain barrier, so it isn't going to probably be used very much. Then another one came along called denosumab, and that, where they get these names is beyond me. That is a genetically engineered monoclonal antibody, and almost nobody is using it because they don't really know how to use it, or it's not as effective as other ones. And then a new radioactive treatment for bone disease came out, which just by itself had a huge response. So there were all these drugs came out, and then last month, the FDA stopped a study that was only 42 months old because it wasn't the guys in the good group getting the drug were doing so well. It wasn't fair to the guys in the placebo group. And they're going to have to study these guys for much longer because they haven't even reached the median of disease-free survival after 42 months, which means half of the guys haven't even shown any inclination to have any disease return. And until they get all those years of data, they won't know what this means. But so far, compared to the other two new ones, they had an 18-month survival advantage. This new drug had a 48-month survival advantage. Never happened before in the history of prostate cancer. It is an amazing change. It's good news for everybody because it's going to eventually filter down into earlier stage disease. They did a small study in Philadelphia. They gave it to men before surgery for 1 year. The guys had the surgery. They couldn't find prostate cancer in the specimen. What does that mean? I'm not sure. But I do know that this new drug, and doesn't have a name yet, it's called darolutamide, but it's on the website. You can read the excitement about it. But it's going to be the drug of choice for virtually all men with newly diagnosed rising PSA after treatment, which is the big group. Men that have had treatment and aren't doing well, it's going to be their drug. And it's really kind of an exciting new medication. I feel badly for the two companies that brought out the other two drugs because their history, they're never going to be used. This one had 7.8% side effects. Placebo had 7.8% side effects. And no more side effects than the sugar pill.
What was the sample in the population?
They had 1,200 people.
Pretty big.
Yeah, big N number. And of course, it's got to be repeated.
Yeah.
It would be the biggest hoax in the world if this is not accurate.
Are they
Now, this is
repeated?
done in
Yeah.
France. And, asking the French for directions on how to do something. don't like to give you directions. So when it gets repeated, but the FDA is going to put it on fast track, and it'll be available in special situations very, very soon. The remarkable thing is the drug could be that powerful and not have any more side effects. Well, it's a genetically engineered drug, which means some engineer in some dark corner in some dark lab figured out how to manipulate it and make it. And it's something that I think, unless it turns out not to be true, is going to be an amazing change in the way we treat. Now, how much is it going to be? I can't even imagine what they're going to charge for it, but they have to give it a name first. The FDA has to approve it, and then, of course, it'll be available. Now, I think there are going to be hardship cases that it'll be available soon, but the editorial and the blogs, I just learned that word from my grandson. The blogs that are on the internet are just very, very much talking about it. And the researchers that aren't excited about anything else are excited not just because of this drug, but if they can figure out how to engineer this drug, what else are they going to engineer? So let's talk about what else they're going to engineer. They have finally figured out why a person stops responding to male hormone. They know what the defect in the gene is. And they've taken kids that have sickle cell disease, and they have changed one little part of one little strand of one little DNA thing and put it back in them, and it stopped their sickle cell. So that's a small group of specialized kids that have a special kind of sickle cell disease. But if they can do that, they're going to be able to figure out what happens to change the DNA. Now we know that women that have breast cancer, that have the BRCA gene, that's a DNA, it's a piece of DNA that helps repair other pieces of DNA. And they know that men that don't respond to male hormones or stop responding, it's because of this DNA change. And so if we knew that ahead of time, we wouldn't even have to give all those other guys the medicine. We could just single out the guy in the blue shirt because he's the one that needs the treatment. Well, this gets back to the genetic testing. It's going to absolutely have to be done if we're ever going to individualize the treatment. So we've gone from doing digital rectal exams, which we don't do anymore. And I remember when I first learned them, they made you take your watch off. Because I don't know why they did that. The other thing that's happening is the programmed death part of the gene. Most cells have a programmed death built into them. They're not going to survive forever. A blood cell lasts for 90 days and then it's gone. Well, they do know that this programmed death gene can misfire and cause a regular prostate cell to become cancerous. So they're looking at the immunotherapy, and I don't know if you watch television, but Keruda is on almost every night. They want you to use Keruda for colon cancer and the ladies off in the fields chasing butterflies. And, well, they discovered that it worked for one kind of cancer. There's a small percentage of men that it'll work for in prostate cancer. They just happen to be the ones that have the genetic defect. So if we knew that from the beginning, we could target that right away, and that person may never then go down the line that what is typical. And this program inhibitor stuff, if that ever becomes like Keruda was the first drug for it. I think it's for colon cancer. I'm not sure what they used it for, but there are 3 or 4 of those drugs coming along. Well, all of a sudden, the urologists and the oncologists are going to steal that drug and try it on men that have that DNA defect. So now we need to do gene studies for another reason, and it's because there is immunotherapy coming that may be even more specific than just the hormone treatment. And then what does this all mean? Well, let's go through the sequence. Primary treatment versus active surveillance. Active surveillance, you get checked frequently. If anything changes, you can go into the active treatment part. So we have that group of men, and it's still about 55 or 60% of men qualify for active surveillance. It's not being used to that degree yet, but in some countries it is. Bernie Sanders wants everybody to go on active surveillance, but we can't do that. That's not right. Then we got radiation plus hormones, radiation without hormones, radioactive seeds, and surgery. Those are the things we do to people. Then if the PSA goes up, that's the newest category. It's the growing category. The pharmaceutical companies are just chomping at the bit to get that 60,000 men because, gee, that's just profit. They estimate that when this darolutamide comes out, it's going to be the first instant billion-dollar drug on the market. Well, if anybody likes to play the market, this is an insider information. Well, we're not doing rectal exams, so I guess it won't be insider, but the fact is Bayer's stock is down because of the stuff you squirt on weeds.
Roundup?
Yeah, they got sued and now their stock is way down from that. So it's a buy from that standpoint. They're the company that's making this new drug that's going to be $1 billion a year drug. Might as well buy it down for another reason, but it goes back up for a good reason, sell it, and then you'll be able to afford the genetic testing. I think that's how it works anyway. The chemo, we're going to sequence this now. Once that stops, that's the sequence of events. There's no evidence that chemotherapy before it becomes, the PSA goes up, helps. No evidence that the vaccine helps. So they're looking at whether or not this darolutamide will help early on, and I'm sure it will. So that will be for a future talk. When the PSA goes up, then the sequence of events is you go back on male hormone suppression. That is standard. And then you consider chemotherapy. The time that chemotherapy helps is when the PSA is starting to go up and there's no spread of the disease. That's the window of opportunity for chemotherapy. The secondary androgen treatments with these new drugs and the vaccine have to be considered at that point. The poor vaccine is just, I don't think, ever going to be as popular as the secondary androgens because it's complicated, it's very expensive, it requires lots of authorization, and it's a little bit messy compared to just taking a pill. Once the disease is metastatic, then you treat the bone with medicine that will prevent fractures, with the particle-emitting radiation medicine, and with perhaps the vaccine. So what's going to happen is this new anti-androgen is going to change most of this because it's going to be so successful that nobody's going to want to wait. I mean, why would you want to wait for the disease to spread before you give it the real treatment? So this sequence of events is now treatment is now starting to take focus. The urologists like it because the drug that doesn't have very many side effects is easy to give to someone. The urologists quit doing chemotherapy because we weren't trained to do it. So you got to go to an oncologist. There aren't that many oncologists that like prostate disease. And so it kind of was in no man's land. Provenge is done by the oncologist. The urologists just are never trained to handle sepsis or handle some of these immune reactions. And so that was always, you had to find an oncologist. Places like UCLA, UCI, and SC have oncologists that specialize in urologic cancers. And those are the people that really should be taking care of this. The guy that's got a primary practice on the corner isn't interested. urology guys mostly aren't interested. It's a lot of complication issues. You have to be able to take care of low cell counts and anemia. And mostly it's an internal medicine oncology thing. This new one is going to go right back into the urology office, and you'll have your urologist, and you won't have to go to a bunch of other ones. It's going to be very, very helpful. We're not sure who's going to treat with the radioactive material. Right now it's strictly an oncology thing, and it's so restricted that you practically have to have gold-plated insurance to get it. Now, Provenge is oncology. So we know that the anti-hormone thing has to be continued if we're going to succeed in treating these two new groups, or the new group and the group that has had metastatic disease. You have to continue the Lupron or Zoladex. There are a couple others that aren't too popular, but we do know that all of the new drugs except the major new one cross-react. If one word doesn't work, none of them work. So you've got three new drugs that cross-react, and you've got apalutamide that is so different it doesn't cross-react. So you're going to want to use the best one, so the apalutamide is going to be the winner there. And then chemotherapy, if it's going to work, it has to be done at a certain time when that PSA is rising, or it just isn't helpful. And they've tested apalutamide on people that have had chemo, haven't had chemo, and it doesn't seem to matter to the apalutamide. It seems to work in either setting. I doubt if most people are going to sign up for chemotherapy in that setting because it makes you sick and all of the side effects when you have a drug that has no more side effects than a sugar pill. Now, if the French got this wrong, we're in really bad shape because the FDA has approved it, and they're going to name it and launch it. It takes a while, but it's going to be here very soon. They're having a contest to see who can name it. But I think apalutamide, enzalutamide, abiraterone, and I've already forgotten one. Well, whatever the other one is, they got to give them names that you can remember. One should be red, one should be blue, one should be green, and one should be yellow. That way you can remember. So that's the exciting news. Almost all the editorials, I brought one of them, are trumpeting the new era in treating the largest group of men with prostate cancer. And the whole thing has to be individualized so that we don't treat the guys that don't need it, and we really treat well the guys that do need it. And anyone in here have had chemotherapy? Would you go through it again? And most people would say no. They don't want to do it again. And I don't think most people are going to have to take too long to decide which way they want to go. I just think chemotherapy is going to lose out to all cancers. I don't think within 5 to 10 years there'll be any chemo. It'll all be immunotherapy, gene manipulation, checking DNA and all that stuff. I think chemotherapy is really on its way out. It's amazing that it's changed, and it kind of snuck up on everybody. But the change is there, and anybody that you know that's in a, we used to call it stage D, or now it's called T3B prostate cancer, they have lots of choices, and there are good choices, and there are ways to take care of the bones, and there are ways to take care of the issues that occur in advanced prostate cancer. So this is the beginning of a new development. I know we all are mature enough to know that nothing's as good as it seems, but even if it's half as good as it seems, it's going to be quite an improvement. And we can quit talking men into having their testicles removed, which was, in my day, I probably did 1,000 of those, and there's 2 on each guy, except that some guys. That's another story. So there's a lot of testicles. We used to do them in the office under Lobo. I mean, I thought I was a vet, you know. That's not gonna be done anymore. So that, and in a lot of ways, that's good. Now, this is the question time, so if you have questions, I got my hearing aids on.
Yes. Well, first
so
of all,
I
let's
will
give
be happy to
Doctor,
answer anything.
let's give Doctor a wonderful. So I have 3 questions here for you.
Oh,
Okay.
boy.
So I'm going to give you the questions and I'm going to let you answer them. So what is the mechanic of this drug? How does it become so efficacious, okay, in addressing cancer? That's number 1. Number 2.
Why don't we take that one? Let's take that one.
I'm sorry?
Let's take that one before I forget the answer.
Okay, go ahead.
They discovered that the androgen receptor on prostate cancer cells undergoes a mutation. And some of them splice themselves, some become variable. They already, I think they call it an androgen receptor splice variant. And when that occurs, the older drugs then don't recognize that as a cell that needs to be treated. The new drug doesn't care what it looks like. If it smells like an androgen receptor and feels like an androgen receptor, it's an androgen receptor. And it's really that simple. It is a DNA, again, genetic, they saw it in the DNA.
Is there any doctor in Orange County or Los Angeles that is familiar with this new drug that you're aware of?
Not unless they were in France. The companies in this part of the world are vying for where Bayer is going to put this. Now, obviously they're going to ransom somebody. I would guess, despite all of their issues, USC probably will end up with it because they've got to hit a home run. They've had so many bad press things that I wouldn't be surprised that they outbid everybody. But the licensing fee for that is going to be amazing.
The genetic testing, is there, are most doctors familiar with that now or using it, or is it just a few, or can you?
Well, that's a tough question to answer because you have to look into the thinking of the guys. You know, there's several types of urologists. There's a guy that's in the community doing his best to treat kidney stones and this and that. It's been very slowly accepted by that urologist. The academic guys have embraced it 100%, which they always do, but the fact that it's so much of a problem getting it reimbursed, the guys in the office have kind of almost given up on it, whereas at the universities they've been subsidizing the, so if you want genetic things, you almost have to be at a university or someplace that is subsidizing that. And it's really bad thinking because you could eliminate a lot of people that don't need these treatments just by individualizing. You know, when they came up with the doing PSAs and the Lupron and Zoladex, I forget, it was Bush 1, I think, was president, and they didn't want to cover it. They just didn't. And whoever was the vice president was Twinkle Toes. What was his name? Anybody remember?
Ford.
For Bush 1, first Bush 1.
Well,
Yes. He ended up getting it into the Defense Department budget. So the Army paid for all of that, and it didn't come out of, so, you know, the Army's got a lot of money. But that was, how that ever happened, that was so strange. And how Dan Quayle would have,
Two questions left. Are you aware of any clinical studies involving this new drug here in Southern California?
I am not aware of who's doing the studies, but they are being done.
There are
Yes.
in the United States.
Yes, it's a drug that's got a code name, a bunch of numbers, and they're actively recruiting. But it's been a very, I'm not sure who they picked. I couldn't find out. It's not like it's a secret, but
I'm gonna give you an invitation here to come back in about 9 months
9 months.
and speak about this drug.
Okay.
Would you do that?
I'll come back when it's approved,
Okay.
because I may have to take that drug.
Thank you, Doctor.
Sure.
Questions?
Yeah, how do you spell darolutamide?
Oh, come on, it took me all this time to learn to say it. Spell it? Let me see. I know I have it here somewhere. Oh,
I can get it.
somebody got it.
Say that again louder.
And it's on the website. It's under something new or amazing new.
Yeah.
And
So
you
it's
just
on
type in it.
it's on our website, okay, and it's on the page that talks about our speaker, okay.
And remember, it's in French.
Ooh.
One of the things when 21 years ago, when my prostate cancer was discovered, is that there was a nodule. So when the doctor did do, the PSA was elevated. I hadn't yet had a biopsy, but he could feel a nodule on the prostate. I don't think it necessarily means it's cancer, right? But there was a nodule, so it felt a little different. But you said he's not going to do digitals anymore. I just wanted to, it's people had a nodule, so that means that.
Yeah, most of the nodules, it turned out, if you biopsied them, were not prostate.
Okay, mine
They had known as hyperplasia that grew that way. And that's the sad part of it, because we really bought into the fact that we could diagnose, and we taught all the residents, and the cuts in Medicare, they won't let you have a glove anymore. You have to have one of those things that fits on your finger.
finger cut. Yeah.
Well, you have to have pretty long fingers before it kind of spills over, and then the rest of your patients wonder what you've been doing. Yes.
So if you're trying to get this genetic testing done,
Yes.
where do you go and what do you ask for? Is there more than one kind of genetic
Yes,
testing?
there are 2 or 3 companies in the space now. The Oncosite 1, 2, and 3, or however they call it, they have a website. It's just the prostate cancer genetic test. If you Google it, they'll send you to the 3 companies. Oncosite is the one I know the most about because I just had Easter dinner with my brother-in-law. That's all he talked about.
So this is just a little bit of more information. Our speakers are extended out for at least 8 or 9 months, with the exception maybe we have one opening. I'm going to speak with the doctor here and see if we can't get the person that is representing the company that does these genetic tests. I'm going to see if we can't get them here on an expedited basis. So watch the website, okay, and as soon as it becomes known, we'll have it on the website.
Yeah, it would be fairly easy to get that speaker. They would tell anybody. We were waiting for a bus the other day and he was preaching, it was terrible.
Question? Any other questions? All questions answered? Okay, thank you.
That's it.
Thank you for the opportunity.